You step into the world of acute toxicology, specifically managing snake bites in the rural tropics.
Hmm.
You are looking at a diagnostic landscape that is incredibly high stakes, rapidly evolving, and, well, heavily reliant on raw, unassisted clinical observation.
It's the absolute definition of diagnostic muddy waters.
Yeah. We're looking at the presentation slides for Southeast Asian snakebite management today. And if you're studying this, you're preparing for a clinical reality where a terrified agricultural worker is going to be rushed through your clinic doors at, like, 2 in the morning.
Yeah, precisely.
Because this is fundamentally an occupational disease.
The epidemiology dictates everything here. We're dealing primarily with rural agricultural workers, so farmers, laborers, people working with their hands and feet exposed in the fields.
Right.
And the timing is highly predictable, actually. Human-snake interactions peak massively during the monsoon season.
Because of the flooding?
Yeah, rising water levels literally force snakes out of their burrows and into closer proximity with human settlements.
But the core clinical problem you face right at the door isn't just treating the venom. It's that the vast majority of people rushing into the clinic were bitten by entirely non-venomous species.
Exactly. What's fascinating here is the psychological element. Many bites are harmless, but the patient is panicked, the family is panicked, and if you, the clinician, are inexperienced, well, that panic is super contagious.
And that leads to bad decisions, I'm guessing.
Oh, absolutely. It leads directly to the most common dangerous pitfall, which is the wasteful, blind administration of antivenom. Anti-snake venom, or ASV, is a precious, highly limited resource.
And it's not risk-free. Right.
Far from it. It carries its own severe risk profile, including anaphylaxis. You cannot just guess. You have to master syndromic diagnosis, which means reading the clinical toxidrome the patient is actually presenting with.
But to read the toxidrome, you first need a mental map of the actual biological weapons these animals are using. To make an accurate syndromic diagnosis, you first need to know what you are looking at. So let's build that mental map. The slides break down a taxonomic identification matrix for Southeast Asia. I kind of think of it like a medical wanted poster.
I like that analogy.
Yeah, we're looking at 3 main venomous families, Elapidae, Vopiridae, and Colubridae. Could you break down the key morphological traits and primary toxins for these? Like, how does a doctor know the enemy here?
Well, the biomechanics tell you everything about the clinical threat. Let's start with the Elapidae family, so your cobras and kraits. Their dentition is what we call proteroglyphus.
Proteroglyphus.
Okay, that just means they have relatively short, fixed front fangs. Because the fangs don't fold back, and because they are short, an elapid often has to bite and physically hold on, they're essentially chewing the venom into the victim's tissue.
Wow, so if a patient tells you the snake latched onto their leg and they had to literally shake it off, your index of suspicion for an elapid should immediately spike.
Precisely. Morphologically, they have long, slender bodies and smooth, symmetrical head plates. There's no loreal scale, and of course they have the ability to spread a hood.
Right, the classic cobra hood.
Yeah. But their primary weapon is their highly potent neurotoxic venom. It targets the neuromuscular junction, blocking acetylcholine receptors.
Contrast that completely with the Viperidae,
Yeah.
the vipers.
Oh, vipers are a totally different mechanism. They are selenoglyphus.
Okay, meaning?
Their fangs are long, hollow, and hinged, operating exactly like hypodermic needles. When the snake's mouth is closed, the fangs fold flat against the roof of the mouth.
Oh, got it.
When they strike, the fangs swing forward 90 degrees. They don't chew. They strike with incredible speed, inject deeply into the muscle or subcutaneous tissue, and immediately pull back.
And morphologically, they look pretty different from cobras, right?
Very. They have robust bodies, triangular heads, and heat-sensing pits.
Evolutionarily, that strike and release makes sense for an ambush predator. They hit the prey with a massive dose, let go so they don't get injured by thrashing claws or teeth, and wait for it to die.
And that tells you exactly what their venom does. Vipers are primarily hemotoxic and cytotoxic.
So not neurotoxic.
No, instead of a neurotoxin that paralyzes the respiratory system, viper venom contains enzymes that utterly devastate the blood's ability to clot, while simultaneously digesting the local tissue at the bite site.
Before we move off taxonomy, we should briefly touch on the Colubridae, specifically the keelbacks in this region.
Right, the keelbacks, they're rear-fanged.
So venom delivery is much less efficient.
It is, but their venom profile is distinct. It's primarily nephrotoxic and myotoxic.
Okay, so wait. I have a pushback here, or just a question. How quickly do these specific toxins actually take effect in the real world? Like, we know the identification now, but what does the timeline look like for the patient?
Well, that's the pivot from the snake's anatomy to the patient's physical presentation. What does the bite site look like, and what is the venom actively doing? First, you have to assess if it's a dry bite.
Meaning no venom was actually injected.
Exactly. Fang marks alone do not confirm envenoming. A dry bite will feature minimal pain and no spreading swelling.
Okay, so what does this all mean when the bite is active?
If there's active local envenoming, you'll see rapidly spreading swelling, severe pain, blistering, and early signs of tissue necrosis right at the site.
So we use the toxin target map from the slides to track the systemic syndromes.
Right. Let's break down the pathophysiology based on the toxin type.
Let's start with neurotoxic.
Neurotoxic venom targets cranial nerves first. This causes pertussis, which is drooping eyelids, and aphonia, loss of voice. Then it hits respiratory muscles, causing flaccid paralysis.
And the hemotoxic.
Hemotoxic causes systemic bleeding. You'll see bleeding gums, epistaxis, hemoptysis, even bleeding tears. And the fatal risk is intracranial hemorrhage, or ICH.
And cytotoxic is the local tissue destruction you mentioned earlier, right?
Mm-hmm.
Leading to compartment syndrome.
Yes, precisely. And finally, myotoxic results in generalized rhabdomyolysis, myobinuria, and acute kidney injury.
Okay, but this brings up a crucial differential diagnosis point from the sources. The psychogenic response. Overbreathing, vasovagal shock, and tetany can mimic severe symptoms.
It's true. Panic is a powerful physical force.
So how does a clinician distinguish sheer terror from actual envenomation? Like, how do you know if it's venom or just a panic attack?
It requires extreme discipline. A severe psychogenic response usually happens within minutes. The patient is hyperventilating, which leads to carpopedal spasms, so their hands and feet cramp up into claws. They might pass out from vasovagal syncope.
It looks like systemic collapse.
It does,
Sure.
but you distinguish it by looking for the specific clinical syndromes and their strict timelines. For Viperidae, you use the diagnostic checklist of spontaneous systemic bleeding and severe local spreading.
And for Elapidae.
You map out the paralysis progression. It's terrifying, honestly. Early stage is heavy eyelids or ptosis, facial paralysis, and a thick feeling tongue.
And then it progresses downward.
Yeah, the mid-stage introduces the broken neck sign. The neck flexor is paralyzed, so if you ask them to lift their head, they can't. They also lose the ability to swallow.
Which is incredibly dangerous.
And late stage is paradoxical respiration, complete descending flaccid paralysis, and eventually asphyxia.
With the grim reality of that venom's progression established, we really need to shift the focus to action. How does the clinician systematically intervene to stop this cascade? The slides outline a 4-stage clinical management algorithm.
Right. We have stage 1, pre-hospital or field. Stage 2, rapid assessment in the rural clinic. Stage 3, investigations in the hospital. And stage 4, intervention.
Let's dive into stage 1,
Yeah.
pre-hospital triage. What are the do's and don'ts?
The do's are simple but critical. Reassure the anxious patient to slow their heart rate, immobilize the limb using a pressure pad, and transport them rapidly to a medical facility.
Okay, and the don'ts? Because I know there's a lot of folklore out there.
If we connect this to the bigger picture, you can see why traditional remedies are so dangerous. Do not apply tight tourniquets.
Why? People think it stops the venom, right?
They do, but it just causes severe ischemia and gangrene. The limb will die before the patient does. Also, do not cut or suction the wound, and absolutely no ice, herbs, or snake stones. They don't work, and they cause massive secondary infections.
Got it. So they arrive at the clinic. We hit stage 2, rapid assessment, which is the ABCs. Airway, breathing, circulation. Now, for Elapidae bites, airway danger is paramount.
Yes. The resuscitation and airway protocol focuses on DRB-CDE.
Break that down for us.
Well, the immediate danger is that bulbar palsy we talked about. It leads to the dangerous pooling of secretions and regurgitation. The patient literally can't swallow their own saliva.
So they could drown in it.
Exactly. So the immediate intervention is physically clearing the airway and positioning the patient laterally so fluids drain out. But definitive care requires endotracheal intubation.
You have to put them on a ventilator.
You must. Mechanical ventilation is required to combat that respiratory flaccid paralysis and keep them breathing while the venom runs its course.
Managing the airway keeps the patient alive in the short term, sure. But neutralizing the venom is the only way to cure them. Here's where it gets really interesting. Let's move from mechanical life support to pharmacological antidote, anti-snake venom.
ASV is the core principle of stage 4. Immunoglobulins are the only specific antidotes.
And they have to be syndrome matched, right? You can't just give any antivenom.
Correct. You have to match the antivenom to the specific neurotoxic, hemotoxic, or cytotoxic syndrome you identified. And a huge point here, corticosteroids and antihistamines are utterly useless for venom neutralization. They should be actively discouraged.
Okay, I have a massive pushback here based on the sources.
Yeah.
The pediatric dosing pearl. The slides explicitly point out that children receive the exact same dose of ASV as adults.
Yes.
That feels totally counterintuitive. In med school, you're taught milligrams per kilogram for literally everything in pediatrics. Explain this rule.
I know it trips up a lot of clinicians. But think about the mechanism. A snake injects the same volume of venom regardless of the victim's size.
Oh, right. The snake doesn't calculate the patient's BMI.
Exactly. The ASV dose is designed to neutralize the fixed venom load, not the patient's body weight. So 60 milligrams of venom in a child requires the exact same amount of antivenom to neutralize as 60 milligrams in a grown man.
That makes total sense when you frame it like that. So what's the trigger to actually push this ASV?
The trigger is clear evidence of systemic envenoming, so neuro, hemo, or cardio signs, or severe local envenoming, like swelling rapidly crossing a joint.
But what if you aren't sure? What if the systemic signs of bleeding haven't started yet? That brings us to the diagnostic anchor of stage 3, the 20-minute whole blood clotting test.
Yes, the 20-WBCT. It is a strict life-saving protocol. First, you extract a few milliliters of venous blood.
Oh,
Then you place it in a new, clean, dry glass tube. You wait exactly 20 minutes, completely undisturbed at room temperature.
no tapping, no shaking.
None. Then you tilt it 45 degrees. Liquid blood is positive, meaning they have severe coagulopathy, and you must administer ASV immediately. A solid clot is negative.
Okay, wait. Push back specifically on the equipment here. Why must it be a glass tube? Almost everything in a modern hospital is plastic now. Can't a resident just use a standard plastic syringe?
If they do, they will likely create a false positive. Glass is required to trigger contact activation of the clotting cascade.
Contact activation.
Yeah. The negatively charged silica surface of the glass activates factor 12. Plastic tubes are neutrally charged, so normal, healthy blood might just stay liquid in a plastic tube for 20 minutes anyway.
So if you use plastic, you might look at it, see liquid blood, assume the venom destroyed their clotting factors, and pump them full of unnecessary horse serum.
Exactly. It has to be a clean, dry glass tube.
Wow, okay.
Now, this raises an important question regarding neurotoxic management. Can ASV alone save a cobra or crate ictum?
I mean, if it neutralizes the venom, shouldn't it?
The answer is no. ASV stops unbound venom, but it cannot reverse paralysis fast enough to prevent early death from asphyxiation.
Right, because the venom's already bound to the receptors.
Exactly. So endotracheal intubation is essential. Furthermore, you need a pharmacological adjunct, a trial of an anticholinesterase like neostigmine combined with atropine.
How does that help?
It is highly effective for postsynaptic neurotoxins. It basically prolongs acetylcholine activity at the neuromuscular junction, outcompeting the venom for the receptors.
And the atropine.
The atropine just blocks the unwanted parasympathetic side effects of the neostigmine, like excessive drooling or a dropping heart rate.
So it wakes up their skeletal muscles without crashing their heart.
Precisely.
Muscles.
That is incredibly elegant pharmacology. Now, let's pivot the targeted management to the hemotoxic and myotoxic bites, the vipers and sea snakes. We know the primary secondary threats here are acute kidney injury from the muscle breakdown and severe coagulopathy. We need to treat hypovolemia with IV fluids, aggressively monitor urine output, and watch for life-threatening hyperkalemia as dying cells release potassium. But the guidelines highlight a massive screaming red flag for surgeons here. Do not perform a fasciotomy for compartment syndrome.
This is perhaps the most tragic error a well-meaning surgical team can make. A fasciotomy is a standard trauma procedure where a surgeon slices open the tight fascia of a limb to relieve the massive pressure of swelling. For blunt force trauma, it saves limbs, but for a viper bite, it is an absolute death sentence.
Because of the venom's mechanism.
Yes. Remember, this patient's blood is entirely incoherent. The venom has consumed all their clotting factors. If you look at a massively swollen, tense leg and decide to take a scalpel to it, you are opening a highly pressurized compartment in a patient with zero ability to form a clot.
Oh my God.
They will simply bleed to death on the operating table, and there's nothing you can do to stop it. The severe swelling of a snake bite is almost exclusively managed medically with adequate doses of ASV to neutralize the tissue-destroying venom.
And I imagine that same logic applies to where we place our needles.
Absolutely. If the 20-minute clotting test is abnormal, you must avoid venipuncture in non-compressible sites, like the jugular or subclavian veins. If you accidentally nick an artery while placing a central line, you cannot apply pressure to stop it, and they will bleed internally. You have to stick to peripheral veins you can actually compress.
It all comes back to deeply respecting the pathophysiology of the venom, and managing that pathophysiology requires a strict ASV dosing matrix. You start with 10 vials administered via a slow IV infusion. You always have a syringe of adrenaline drawn up and ready at the bedside because anaphylactic shock to the equine proteins in the antivenom is a real and terrifying possibility.
Yes, you have to be ready for it.
And the timing for repeating that ASV dose depends entirely on your dynamic reassessment. If their blood remains incoagulable after 6 hours, you repeat the dose. If they develop brisk, spontaneous bleeding, you aren't waiting 6 hours. You repeat in 1 to 2 hours. If their neurotoxic signs are worsening, you repeat in 1 hour.
It demands relentless clinical vigilance. You are constantly reading the patient's physiological responses.
So let's bring all this together. If you are that clinician standing in the rural clinic, here is your high-yield blueprint. First, accept that identifying the specific snake is a luxury you likely won't have. Rely on the syndromic diagnosis. Read the story of the bite. Is it spreading? Read the clinical syndrome. Are you seeing the descending paralysis of neurotoxicity, the spontaneous bleeding of hemotoxicity, or the deep muscle breakdown of myotoxicity? Follow the first aid rule, immobilize with a pressure pad, prevent psychogenic panic, and absolutely no tight tourniquets or cutting. And finally, take definitive targeted action. Protect that airway from bulbar palsy, use glass, not plastic, for your clotting tests, and administer the correct syndrome-matched antivenom based on venom load, regardless of the patient's size.
It is a phenomenal, rigorous, life-saving algorithm.
The actual landscape of the emergency is shifting beneath our feet, and it brings us right back to our original reality. When you step out of the pristine trauma bay and onto that dirt road, the rules change. The high-tech scanners won't save you here. But deeply understanding the mechanisms of venom, respecting the pathophysiology over the Hollywood myths, and learning to read the clinical syndrome like a map. Mastering this high-yield guide won't just help you ace a medical rotation. It will unequivocally equip you to save a life in the field when the pressure is truly on. Thank you so much for joining us on this deep dive.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.